there's a split of the spinous process. So it's a clear indication for stabilization. Burst type of fracture in the front. The disc certainly is destroyed. So we're doing intraoperative navigation for that. This is a mobile 3D scanner. This is what is called an O-arm. So the difference is from what you heard with Frank, that this is not stationary in the OR. You can move it like a fluoroscope from one OR to the other, and that makes it very flexible. So this is the situation afterwards, after that stabilization. Posterior instrumentation and anterior 360-degree reconstruction. In this situation, that it was only a cranial burst. We did not do a fusion of the lower segment. So this is how it looks 9 months post-operatively prior to the removal of the implant, because that gives for the patient back the lower segment. This is the function of the lady afterwards, after implant removal. We have published a study about how you could enhance this cage interposition if you're using navigation. And yes, if you're using navigation upon cage placement in the anterior spine, it is more precise. It is, sometimes you see the cage is a little bit tilt, or you see the cage can hurt the end plates if you're not working very precisely, and that may be a situation where cage subsidence may be a consequence. So computer-aided measures can help to more precisely place the anterior cage. This is just another case, a C-type of fracture with a bisegmental cage placed, and you see how precisely you can place the cage without any tilt, without any shift towards the left or right, if you use that navigation. Also, we use the fluoroscope, and that will be the surgical flow. The patient is positioned in a lateral decubitus. The portals are being marked for the video scope and for the suction device. Here you can see them in place. This is a pedal to retract the diaphragm and to get full view on the spine. So it's very nice, can be seen very nicely. Again, it goes along with the intraoperative CT, and this is the cage placement then with the help of navigation to be very precise. Sometimes, especially in the aging spine, we are having these situations that if you do not consider compromised bone quality, it may look nice at the beginning, but this is what happens at 3 months post-op, because there is generalized osteoporosis. And of course, this sort of short segment stabilization cannot give any stabilization. So we're dealing with a post-traumatic deformity now, and this is much more complicated to treat with than it was initially, of course, because we have some partial consolidation already. We are having some contraction of the anterior ligament, and this usually needs a 360-degree single stage or double stage revision strategy, and this is how you can do it. The patient here is positioned in a prone position, and we're starting with the posterior reinstrumentation and with the posterior release in combination with intraoperative navigation, as you can see. Mini open to get access to the anterior spine, and also with the help of a video chain, and that will be the solution afterwards with cement augmentation of the pedicle screws. And also, if you look closely, the cage does not rest on the end plates because the end plates don't have good bony structure. The cage is resting initially already on the cement. As you can see here in the CT scan postoperatively, the cage does rest on the cement block that was used to also augment the pedicle screws. Here you can see it on the coronal plane, and this is the 1-year follow-up with no loss of correction, with no subsidence, no further subsidence of the cage, and another case of post-traumatic deformity. That was a conservative treatment in a 61-year-old male, and this patient fell from a tree 4 months ago. You can see how it healed. Basically, it did not heal. And of course, this causes permanent pain, so you're again dealing with post-traumatic deformity here. And if you go to literature, what are the indications for surgical correction in post-traumatic deformity? Worsening, non-treatable pain, or onset of neurological symptoms. So in this situation, because of the permanent non-treatable pain, that was a good indication to do surgery. And here you again can see the setup, how we do it. So this is a single stage approach that is exclusively done in the prone position. The patient remains in the prone position for the whole surgery, and you're working with two teams. One team is doing the posterior, standing on the right side of the patient, and the other team is doing the anterior part at the same time, sitting on the left side of the patient. And that enables you to save time. Of course, it's logistically challenging, but you can save time with doing that. And also, if you're using, you can also use the 3D scanner here and navigation. This is the anterior part, and this is how it looks like post-operatively, with a realignment, with long segment stabilization and an anterior cage. If there is any neurological deficit, you're dealing with a spinal trauma with a deficit involvement. Like in this situation, a 38-year-old male came with this L1 fracture. You see the posterior wall fragment having protruded into the spinal canal with a Frankel C situation. This is an emergency situation. You will go in there immediately, of course, and then do some stabilization along with the decompression. That was done here also. Reduction and laminectomy. You see how by the reduction already, the posterior wall fragment flips a little bit back into its original situation, but still there is spinal canal compromise. And this is when we go forward and do the next step. We are targeting, during our anterior approach, we're targeting the posterior wall with a navigated chisel. And this is how it looks like intraoperatively. You see how the chisel can be targeted directly towards the posterior wall fragment. You can mobilize the posterior wall fragment very safely, very securely, and you can finally distract the entire posterior wall fragment and have a nice view on the dura with a full decompression, both posterior and anterior of your spinal canal in this neurologically compromised patient. So the patient, again, here you can see after the first surgery, posterior stabilization, laminectomy, and after this second surgery, synopsis for you again with the full resection of the posterior wall, and the patient recovered from the neurology. So in conclusion, what are the in trauma surgery, what are the options where you can use computer-assisted navigation? Of course, you can use it placing your pedicle screws. That is very evident. That is very proven. If you look into the literature, revision rates are much lower using these devices. But you can also use it for anterior navigation. You can use it for placing your cage very precisely where it should be. Also, as I have shown you with this case, you can use it for resecting a posterior wall fragment in cases with neurological deficit. This can be sometimes very tricky, and it really helps to add safety and efficacy to your procedure if you're using computer-navigated aids for this. Finally, Frank has mentioned it already, considering the fact that, of course, getting an image intensifier like this, an intraoperative CT scanner, an intraoperative 3D scanner, whatever you prefer, of course it has some costs involved, but considering the lower revision rates that you definitely have, it can be cost-effective very soon. So I come to the summary. This MIS technique with a video-assisted 360-degree reconstruction technique is safe and is effective. If additionally you use the navigation it would add more safety to the procedure, and also, as we have heard in the first lesson, of course, reduce your radiation exposure, and also the costs regarding the fact that revision rate will drop. And finally, in post-traumatic deformity cases, personally, in my institution, we favor one-stage procedures, which are logistically a little bit challenging, but for the outcome, for the time of overall surgery, I think they are favorable. So I thank you for your attention.